Okay guys, I'm back. So let's finish talking about arch bars. So on page 710, look at the picture of the arch bars. There's two bars that one goes on the maxillary portion and the bottom half goes on the mandibular portion. So on the top, see how the little circle is arched up, and on the bottom your little circle is arched down. So that little circle is there for you to wrap a wire around. This is how we wire the mouth shut. So after they place the arch bars, they're going to ask you, the scrub tech, for a wire. So basically there's one of two options. You're going to either give them a straight wire or what's called a fish. So typically they're going to ask you to get a straight wire and curve it around and make it look like a little fish, like a little goldfish or a Jesus fish. So basically, to hand these over, you're going to have to attach them to a wire driver. So for your fish, like that, and for your straight wire, like this. So these will be threaded through the teeth and then tightened down so that the wire, or the mouth, will be wired shut. Before you do this is an important part for the scrub tech. So you're going to have to imagine that this is going to straighten for me, because this is a paper clip, not a wire. So typically you're going to have two wire drivers and your wire in the center, and before you hand it to the surgeon, you're going to pull it and stretch as much as you can. The purpose of this is you want to stretch it out now so that it does not stretch out inside the patient's mouth. So every wire you get, you're going to have to pre-stretch it and then communicate with your surgeon so you know how to pass the wire straight or twisted like a fish so that they can twist it down and wire that mouth shut. So looking at your picture, make sure you know which side is which, the up arch and the down arch. Also know the instruments you need to have. So even though I only have a needle driver here, a wire driver is very similar. It's just thicker on the end so it can really take that twisting of the wire. So of course, always have your wire cutters available. So at the bottom of 710, I'll remind you again, airway emergency, you have to send the wire cutters with these patients in case they wake up vomiting, bucking, have an airway emergency. They have to have those wire cutters with them. Okay, let's look at plate and screw fixation of a mandibular fracture. So I like mandibular fractures, they're pretty cool. There's lots of different ways to approach them though. So I've put a couple videos on the YouTube channel so you can watch the different ways that they're going to fix your mandibular fracture. Because we're working on bone, we're going to have a lot of bone and orthopedic instruments. So you're going to have elevators, freers, rongeurs, different things to help with bone. So for these cases, it's going to be for misalignment or malocclusion. Now, they can go hand in hand. You could do arch bars and a plate and screw on the mandible. Just depends on how bad the fracture is. One of the videos I posted, they actually put a plate and screw on the mandible and then finish by wiring the jaw shut. So these wires will be cut out later on after the fracture has begun to heal. So if you look at page 713, this is one of the most important things you'll learn for orthopedic surgery. So this is your same routine that you're going to do with any case that you're doing plates and screws. So you can start on number 3, but I'll go through the order in more simple terms. So drill, depth, tap, and then screw. So numbers 4, 5, 6, and 7 are what you need to know in that order. You will do that exact same thing with orthopedics every time. So drill, you measure the depth, you tap it, and then you place your screw. So because it's your job to measure, you need to also add in, because it's not in your book, you can add it near your pearl of wisdom, that the most common screw is a 4mm screw. Now they're still going to use the depth gauge, they're going to measure, but in general we use a 4mm screw on mandibular fractures. Okay, turn to page 714, orbital floor fractures. This makes me smile because I have a lot of really good pictures about orbital floor fractures now. So thank you, Brittany to your brother, for sharing all those pictures, and it's actually on your slideshow on MCC. So you can have a real life view of what these cases actually look like. It's actually very hard to find good pictures, and now I have a lot of good pictures thanks to Brittany's brother. So as you're studying the surgical anatomy and pathology, make sure you know what each orbit consists of, and I want you to know all of your craniofacial bones. So frontal, lacrimal, ethmoid, maxilla, zygomatic, sphenoid, and your palatine bone. So that's 7 bones. So make sure you know your 7 bones when studying for this exam. Look down at equipment, instruments, and supplies. So for these cases, you could have implants. So you want to make sure to read the surgeon's preference card to see what type of an implant they're going to use, if any at all, for these cases. Typically, it'd be something like silastic sheeting to kind of put down on the orbital floor to protect that area and maybe to protect the eye also. That just depends on the fracture. Look at page 714, and I'm going to point out some important things about the case. So looking at number 6 on page 715, you're going to need, it says a moistened orbital retractor. So these retractors, you actually already know, they're called malleables. So the big long ones you have in general surgery, same thing but smaller. So you're going to dip the orbital retractor into probably sterile water. If it is coated in Teflon like it talks about, you can dip it in saline and it will not erode that instrument at all because it's covered in that Teflon coating. So you want to do that so it slides nice and easily and we don't damage the eye. So make sure you moisten your retractors on these eye cases. And then if you look down at number 10, it talks some more about that silastic sheeting being able to support the globe at the end of these cases. But very similar to the mandible fracture, we're going to do plates and screws. So that same order that you already learned. It's going to be the exact same pattern and the same thing for orthopedic surgery. So if you learn it now, you'll have one less thing to learn for orthopedic surgery. Okay, look at page 716. Let's look at the Lefort fractures. So I have a really good picture on your slideshow on this one because for me it was a little confusing on what they are fixing on each Lefort, 1, 2, and 3. So I'm going to have you write some notes on what we're fixing, but I want you to look at the slideshow because it lights up the difference for you. And for me it made it black and white. So let's start with Lefort 1. So Lefort 1 is typically your maxilla bone. I knew I brought Lacey here for a reason. Lefort 1, maxilla, all down at the bottom right here. So Lefort 1 is going to be your most common type of fracture. Less common, Lefort 2. So this one goes a little bit higher. So it extends up into the nasal bones also. So maxilla and nasal and ethmoid bones. So if you're making notes, Lefort 2, nasal and ethmoid bones are included also. Lefort 1, just the maxilla. And Lefort 3. So this one's going to include one more thing, and that's your zygoma. So it could be all the way down here, still considered your zygoma. So even though it's not part of the arch, it could be lower down, it's still part of that procedure. So if you look at your picture on page 717, you can see where that cutoff is. Sometimes it goes all the way up here by the eyes. So it looks like it's part of the orbital rim, which it is, but that bone is still called your zygoma bone or your zygomatic bone. As you're studying this one, you should go over a little bit of anatomy too. Make sure you know those facial bones. Make sure you know alternate names, like on page 716, it talks about your zygomatic bones also being called malar bones. So these are your prominences of your cheeks. Make sure you know both of the terms for that. Another one would probably be your vomer bone, another one to go over. So hopefully you went over that in ENT surgery, but if you don't remember where your vomer bone is, then you should review over that anatomy. Okay, those are your 3 Lefort fractures, your facial fractures. So I want you to go all the way to page 721, our last section. So orthognathic surgery, that is how you pronounce it. So this one is to correct your jaw alignment and occlusion. So this one can look pretty severe actually, but it's just to fix the jaw alignment. So if you have a big underbite or a big overbite, they can actually fix it this way, but it's pretty involved. So the surgical procedure involves splitting the lower jaw into 3 parts. So basically they split it into pieces and then they attach it to the walls so that it has the right alignment. If you keep looking, they can do the exact same thing to the upper jaw. So they're going to split it at the palate up at the top into multiple pieces and then attach it at other places so that it's fixed in the correct place. So they don't have an overbite or an underbite. That misalignment has been fixed now. And that's all I have actually. So I've gone over all of oral and maxillofacial surgery. One last reminder for you, you can please type your questions underneath the lecture, and same thing with your workbook page questions. We'll do the same thing every week. Eventually I will be lecturing from home, so it'll still be the same routine. Be sure to put your questions underneath instead of sending me personal messages. But if you have any other concerns, anything we need to talk about, of course, send me a personal message. I'm here to help you out, okay? You guys have a great day. Talk to you soon.